My name is Christina Bailey. I'm the Director of U.S. Sales. I'll be joined tonight in moderating by Eric Gellinger, our Manager of Sales Training. We have roughly 50 U.S. physicians on the call tonight. I want to thank you all for being here and welcome you. I'm very honored to be doing this and excited to be doing the introduction. So we're fortunate to have Dr. Zachary Arthurs with us to share his presentation. But before we do that, I want to share just a few of his professional highlights. So Dr. Arthurs is currently a vascular surgeon at the Coastal Vascular and Vein Center in South Carolina. He's a highly awarded retired lieutenant colonel in the U.S. Army. He did his undergraduate work in chemistry and nuclear engineering at West Point, attended medical school at the University of Oklahoma, residency at Madigan Army Medical Center, and his vascular surgery fellowship at the Cleveland Clinic. You're probably all familiar with his name and his works, but we're very honored to have him tonight. Dr. Arthurs, the floor is yours.
Thank you, Christina. Is the audio okay?
You sound clear.
Perfect. Let's get started. Everyone, thanks for giving us a little bit of your time tonight. I appreciate it. I will kind of go over my disclosures. I do believe in EVAR as standard of therapy for treating aortic aneurysm disease. It is the future. I do not believe that we're ever going back. And it really comes down to perioperative mortality. That drives everything for me and my patients. And for that reason, the technology has to improve and only get better. AFX2 is my graft of choice, and it's still my graft of choice today. There are a lot of critical aspects about the graft that make it my favorite. My original graft of training that was kind of my bread and butter bicycle, so to speak, was the Cook Zenith graft. And then as I grew into my practice and became more comfortable with AFX, it became my graft of choice. I do believe that outpatient EVAR is attainable, and I think that's where we're going. I've worked with Endoleaks in a lot of areas, consulting, but really on their cutting edge technology. I was a big part in Ventana. I held a role as a clinical adjudicator in the LEOPARD trial, and now I'm working with them on occlusive type devices, which is kind of exciting stuff. I also work with other companies and other trials and other rare areas that are all related to the aortic space. So I want to start back at kind of where the temperament was and is with the FDA. This is a talk that I gave back in 2016 at the Stent Summit. The Stent Summit is held at Cleveland Clinic every year, and now it's migrated to Boston with Matt Eagleton. But the FDA is always in attendance at this meeting, and a big piece of it is on the clinical safety and regulatory piece of EVAR. And the big concern was that we started to get some reports that EVAR outcomes were not as positive as we had thought, and there were some surprises. And this is the paper that really triggered it all. Mark Shimmerhorn did an incredible paper out of the Medicare database. And what makes this database so strong is that, number one, it's a large dearth of patients, 45,000 patients over about 4 years. It is able to be propensity and demographic matched. But the other piece of it is that if your EVAR is put in New York and you have a reintervention done in California, this database will pick that up if you're a Medicare patient. And so it stems the problem that we've had with lost follow-up and being able to track patients. And we're actually able to see what the real world event rates are for things like reintervention, things like rupture, things like death from EVAR. So really an incredible cohort with 22,000 patients in each arm, comparing just EVAR to open surgical repair. And what he found was, kind of what we already knew, which was that early on, all-cause mortality with EVAR is 1.2%. Open surgical repair in the United States has a perioperative death rate of 5%. And there's this crossover point right at 36 months. But the big question mark is these two lines, they're not parallel. And EVAR, if EVAR was as good as it should be, and there's no reinterventions, no aortic-related deaths, this line should parallel and stay away from open surgical repair, and if anything, plateau off and their mortality should stabilize, but it doesn't. And it looks like when you look here that they're actually going to cross, and there's the opportunity for open surgical repair to have a better mortality at 5 to 8 years. And that raised a lot of red flags. And the reason was why? Well, he went back and he looked at the 8-year database, not the 5-year database. And if you look, the EVAR rupture rate, this is the first time that we're able to really capture a rupture rate post-EVAR. And I got to be honest, before this time, I was telling patients that they were protected and that the rupture rate was negligible at less than 1% at 10 years. The rupture rate here at 8 years is 5.4%. It's basically 0.5 to 1% per year. So for a 5.5 centimeter aneurysm, we're reducing them from 5.5% per year to about 0.5% to 1% per year. And this was alarming. And what was really alarming is that we know that the open surgical rupture rate is much lower. It was only at 1.4%. So a big delta here. And the big question mark is why? What's going on with EVAR? And are we missing events that we're not capturing with our routine surveillance and our follow-up? Well, if you look at the reintervention rate, the reintervention rate was much higher for EVAR, 25% versus 21%. And so there's about a 4 to 5% difference in the reintervention rate. And I think we all kind of knew that EVAR had a higher reintervention rate, but I don't think any of us was using a number of 25% at 8 years. That was much higher than I anticipated. And this is the slide that really is the takeaway of why EVAR mortality is affected. I hope it projects to you, but the top blue line here is open surgical repair without reintervention has the best long-term survival. Open repair, no reinterventions, the best long-term survival. That was a shocker to me. So that early mortality benefit is lost if they have no reinterventions. It's better to have an open surgical repair and not need a long-term reintervention from a mortality standpoint. The green line is EVAR without reintervention. So if we can design a device that has no reinterventions, the mortality parallels that line and gets the outcome that we want. We get the benefit of an early perioperative mortality reduction, and then we get the long-term durability and the long-term survival that we want with open surgical repair. So that light green line is EVAR without reintervention, and that is our goal. That should be our goal for EVAR engineers and for companies and surgeons, is we want a device that really does not require interventions. If we look at open surgical repair with reintervention, it's this red line. So the mortality is reduced dramatically. But what was alarming to me was that EVAR with reintervention has the worst outcomes. So just think about that. Before this, I got to be honest, I thought EVAR reinterventions, type 2 endoleaks, cuffs here, I thought that they really had a minimal to no impact on mortality. And that is not the case. EVAR complicated with reinterventions is what drives the mortality loss and what is the problem with EVAR outcomes in total. And this was a red flag for the FDA. And this made EVAR a target for the FDA to examine. And they started collecting data from that point forward to examine why EVAR mortality with reinterventions was so high. And I think we all know that type 2 endoleaks, they drive the reintervention rate. The majority of reinterventions are related to type 2 endoleaks with sac growth. And so we can describe it as a persistent or a new type 2 endoleak, but we know that those endoleaks out of the quality initiative from the New England Vascular Group drives the reintervention rate and is what plagues that reintervention rate. So let's talk about AFX and device evolution. I think we're all aware that with the strata material, initially there were reports of type 3 endoleaks that came out from graft separation. And then with that came the type 3B concerns. At the initial reports, it looked like a big signal and it raised concerns. And during that time, I think that Endologics handled it appropriately. There was a fully transparent deep dive into the data to look how serious this was. In retrospect, I think the type 3A was a learning curve. I think we learned from that. Me personally, I trained through the era of fenestrated endografts in evolution. And the very first fenestrated endografts, the Cook device, it was built with a single 22 to 24 millimeter sealing Z-stent. And the infrarenal piece was made to mate with it and have just one sealing stent bridge that gap in the middle. And it was about as close as you could get to an AFX device. And that sealing stent, in many of the cases, it's separated. And we learned to appreciate that endografts do have lateral movement within in the aneurysm sac, that the what we thought to be laminar flow is not accurate anymore. You actually have spiral flow through the aorta, and that spiral flow creates lateral energy that causes lateral migration, typically to the patient's right and into the anterior wall. And with that lateral migration, you can get graft separation. And I think with planning, we've realized that you really need 4 to 5 centimeters of overlap between those devices to have a secure connection and to account for that migration. And then the type 3B endoleaks, I think those came out in a spattering, whether that's lot numbers, whether that's institutions, whether that's technique, ballooning the bifurcation. In any regard, I think with DuraPly and then following on with AFX2, all of those concerns were addressed, and we'll show you the data to deal with that. In my own personal experience, I was a near 100% AFX user besides fenestrated cases. We looked through all of our cases. I know it sounds unbelievable, but about 70 to 80% of my AFX cases, I put in a third junctional piece. And a lot of that was because of length. A lot of that was because of the sizes we had at the time. Most of the main bodies I put in was an 80. And so my type 3 endoleak rate was probably so low because I put 3 pieces in most patients that had a length of 100 to 120 so that I could get the maximal effect of the fabric at the sealing point and then ensure that I had a good seal. And so that was more of a practice pattern difference that really equated to that. And then for reasons I can't really explain, I don't balloon the bifurcation much at all. I really just mold the iliacs. And I can't really explain why my type 3B endoleak rate was 0, but it wasn't. That's not to say that the 3Bs don't exist. I've reviewed multiple scans, multiple reports, and seen multiple CT scans to where there were type 3Bs. But in my own experience, I was lucky enough not to have any. And so the FDA put out this warning that I'll share with you. Most of you have probably seen it. It's educational in part. But I think that we do need to highlight number 3, which, depending on how you interpret it, says that besides using an AFX2 device, you should consider available alternative options. And that's fairly ambiguous, but there is the implication that for some reason, maybe AFX2 is not as good as other devices, when I think the 3A and the 3B concerns were really in now, today, old generation devices. I think we all agree that there were those problems in the past, but today with AFX2, I think if we do a deep dive into the data that was submitted to the FDA right now, I hope that you will see the value in AFX2 in your practice. The LEOPARD trial is an incredible data set. As a surgeon, I'm appalled that we have so little level 1 data in vascular surgery. And when Endoleaks brought up this idea, I was so excited to jump on board. This is a company, number one, that's willing to fund it. And I've heard criticism that, oh, it can't be level 1 data if a company funds it. I can tell you today that there's randomized trials in cardiology, and they're all funded by industry. There is no funding source today that is going to pay for this trial. So if anything, I think we should applaud the company for investing capital with little to no reward on answering this very hard question, which is there a difference between devices, number one, anatomic fixation versus a proximal fixation device that relies on barbs and a self-expanding stent to obtain seal? To get randomized data, I was incredibly excited. They designed it in such a way that it was a head-to-head comparison. The surgeon was allowed to pick which cases to enroll, and at that point, they're randomized to their proximal fixation graft of choice versus AFX. Total, we had 60 sites included with an incredible follow-up of 5 years, which I thought was extremely remarkable, knowing that it'd be very costly. So when we look at data, this is the only randomized data we have in the EVAR space. There is not another randomized data trial with external monitoring like the LEOPARD data. This is the most valuable data set we have. Even our meta-analysis, most of our meta-analyses come from uncontrolled data. They come from registries, they come from self-reported institutions. Even our meta-analysis data is really not level 2. It's really a conglomerate of uncontrolled longitudinal studies, which is really level 3. And even MDR reporting is down at level 3. So this is as good as it gets for us. And before this is what we were all asking for. We all said we need level 1 data. We need level 1 data. Every other specialty has randomized trials to base their decision on what type of technology to utilize. And now we have it, and it's incredible. So across these 60 sites, there are 230 patients randomized to Duraply and AFX2. And then the other grafts, Endurant, Excluder, and Zenith, fairly equal distributed, maybe a shift toward Endurant, but fairly equal. The overall patients treated with the randomization process, very symmetric. Size is about the same, the neck diameter is about the same, iliac diameter, aortic angulation, and then even the off-label IFU rate was about 1/3, which I was impressed with. So what are the outcomes? The primary endpoint was freedom from aneurysm-related complications, and it's a conglomerate endpoint that was predefined. It includes rupture, any periprocedural death, conversion to open repair, endoleak creation, limb occlusion, migration greater than 10 millimeters, sac enlargement, and any AAA-related reintervention. And if you look at freedom from ARC, AFX clearly is 10 to 12% points better. And it's throughout. This early event rate stabilizes out. And the thing that encourages me to say that there's really a difference is that the two lines are separate and parallel each other. There's no inclination that they're going to cross. And if they do cross, it's going to be well past 5 years. So there is a benefit out to 5 years with the AFX device and its technology compared to the proximal fixation self-expanding arm. And if we break it down into the separate components of ARC, freedom conversion, there's really no difference. Converting to open repair with either technology is really not a concern. If we look at freedom from limb occlusion, this is subtle, but there is a difference. And I see this in my own practice. AFX limb patency, 5 years at 98%. That's pretty incredible. For iliac limbs, that's pretty remarkable. And I think that we all do know that the limbs are able in the AFX device to be custom fitted to your iliacs. With our comparators, those limbs range from 13, 14, 16, and may or may not fit through distal aortas. I think this is what that data is falling out. And it is. It's a 3 to 4% patency difference between those groups, but it is a subtle, small difference. When we look at endoleaks, this is the big one. Type 1 endoleaks, both technologies do very well. There's no difference at 5 years in the type 1 endoleak rate. What there is a big difference is in the type 2 endoleak rate. And if you look here, freedom from type 2 endoleak rate is about 10 to 12 percentage points difference at 5 years. And the AFX device plateaus out. The proximal fixation arm, the self-expanding stent arm, it tends to actually fall off. And it looks like it's continuing to drop beyond 5 years. But there's a big difference here. And we already talked about it. Type 2 endoleak rate is what drives the reinterventions. Reinterventions is what drives that mortality at the 6 to 8 year mark. So these type 2 endoleaks for me are one of the most important aspects of how and when and what device I choose for EVAR, because this is the Achilles heel of EVAR right now. This is the problem that we have not been able to solve to halt sac progression and reintervention. And if we look over here at type 3 endoleak rates, which was the signal that we were all worried about with Strata, there's no difference. The type 3 endoleak rate after with Duraply and AFX2, it is the same as all other devices. And if we just look at the AFX arm, it's 1.5%. The type 3 endoleak rate signal is gone. Now that we have Duraply and we have AFX2, there is no type 3 endoleak signal. And this is in a randomized trial, core lab, externally monitored, externally adjudicated. This is as good as the data will get for us. This is another data set that helps kind of give us some more insight into AFX2, again, to assess the durability. This is a group of surgeons, Dr. Garrett, Vetch, Thompson, Lombardi, across 5 institutions that conglomerated 405 patients out of their data set to really examine this signal. This was a response to the type 3 endoleak concern. And what did they find? The exact same results that we have from the LEOPARD trial. All-cause mortality was the same as the LEOPARD trial. Freedom from aneurysm-related mortality, the same as LEOPARD. Conversions, the same. Aortic rupture, freedom from aortic rupture, the same. Type 1 endoleak rate, less than 1%. Type 3 endoleak rate, there is no signal. It's the same as LEOPARD. Secondary reinterventions, again, very low at 8%. It was actually a little bit better than LEOPARD in their report. But overall, the thing that I'm really looking for is this reintervention rate, and the type 3 and type 1s, they're just not there. It's exactly the same as LEOPARD. So another confirmatory body of data to show us that it's a strong device. So putting it all together, the type 3 story, just to put it away, and the reason we're really doing this is because the FDA's concerns is surrounding this single topic. Even in the peak of concern with everything grabbed, the highest the rate ever was at 4 years was 3%. And I know there are centers that reported some pretty ominous numbers, but the real numbers across the board for the type 3s at the highest was 3%. Once DuraPly came on board, we dropped it down to 1.4%. And now with AFX2, it's less than 1%. And that's from 2016 forward. We're 7 years past new technology. There's no doubt this was a concern. I don't think any of us like the 3% rate, but in the grand scheme of things, even 3% is not as alarming and ominous as we once thought it was. I think it was a critical signal. We looked at it, but now that we have this full story in front of us from 2011 to now 2023, I think we can see that the new device is as good, if not better, than the other devices out there. So putting it all together at 4 years, using all of our data sets, the type 3 endoleak rate currently for AFX2 is right at 1% across the board, which I think is extremely respectable. Additional data that the FDA was able to analyze, the CMS data of 21% comparing all primary endpoints, EVARs versus AFX2, there was no differences in that data set using the CMS data that was available. Using our own VQI, another 20,000 patients, data that we support and protect, the EVAR complications at 3 years, reintervention rate, no difference, and the rupture rate, 1.6% in both groups, no differences in that data set. So again, conforming the performance of AFX2. So what are my conclusions? They're exactly the opposite of the report that you received from the FDA. I think that with all devices, the post-EVAR rupture rate is right at 0.5 to 1% at 1 year, and it grows cumulatively with each year to where it's 5 to 5.5% at each year. And that's from the Medicare data that I showed you at the beginning. The reintervention rate is the problem. It's 11% at 3 years. It's 28% at 8 years. That reintervention is what drives the latent mortality of EVAR. And for me, the type 2 endoleak is the key. And if anything, AFX2 has the lowest type 2 endoleak rate, therefore the lowest reintervention rate. And I would pretend it at 5 to 8 years to have a better mortality. And I think their ARC endpoint shows that with that 10% difference in the two lines paralleling and not approximating each other. The 3A and 3B rates are low. Starting back in 2011, we can see the full story now. And when we look at those rates in a monitor environment today with AFX2, it's right at 1%. And I don't see the type 3 endoleaks rate. It's not even a concern for me now when I make a choice. My own opinion, I use AFX2. I love AFX2. I still use it for ruptures. I still use it for infrarenal aneurysms. And I think the rates, if anything, are comparable to all other endografts out there. I think the technology and the anatomic fixation is superior. And I also think that it has a lower type 2 endoleak rate If there's questions about that, we can get into it. But there's many reasons that I believe that that's the case with that technology. So taking a step further, that's what happened in the U.S. It was extremely eye-opening in 2011 to 13 when the concerns kind of started to raise. I was amongst some international physicians, and they highlighted what a small issue it was for them, that they didn't see that signal as a concern at all. And in many countries like Japan, AFX still had a large majority of the market share. That was a big number. It was remarkable. And some of the EU surgeons even were still using AFX and had no concerns with the device. And so it kind of highlighted that it was a local US problem with that concern and the interpretation. And if you don't know, the EU regulatory process in order to get a device approved just became extremely more stringent. And this is the equivalent of the FDA process to get devices regulated in the EU. And the EU came out with a device directive that all companies had to go through. And it's a series of safety, quality, and fiduciary points that a company has to meet in order for them to authorize that device to be used. And it's extremely arduous. You don't have to read the bullet points, but just understand that all companies had to generate a lot of capital to invest to jump through these hoops and get their device updated. The other piece was there was no grandfathering. Every device had to go through this new process in order to get it recertified and bring it up into concordance. And what it equates to is more money for companies to invest to provide more data. It takes more time. It takes more analysis, more annexes, and a larger portfolio, which if you look to the right, it requires 120 something articles, 17 annexes. You have to jump through these hoops with rules and pages. But their goal was to ensure maximum safety. And this process is above and beyond more difficult than the United States process. And despite going through all of this, with the AFX device, ultimately, the EU granted them the new MDR approval. So they have international recognition and validation of their device. And so just putting it all together for the evidence that we have out there supporting AFX2, now you have international recognition with the EU approving their device for safety and use in Europe. We have randomized data, which is the only randomized data supporting AFX, and if anything, outperforming the other devices. We have our own national quality registry through the VQI supporting AFX. We have national data, and we have most post-market surveillance. And when I interpret this, there is nothing that gives me any pause about using AFX2, and which is why I still use it today. So at this point, I think we can open it up for questions. And while people are just kind of gathering their questions, we can either do it through the chat portal or they can open up to their speakers. I would say that, you know, how does the FDA come to this? And I'll just leave you with some words that, you know, as clinicians and as physicians, we have to make our choices on how we interpret the data and what we think is the best for our patients. And another example that is very impactful for me was the drug-eluting stent discussion that came out. And the way the drug-eluting stent came out with paclitaxel was an extremely poor conglomerate of meta-analysis of a single institution that put together, they did some statistics, and when they did their statistics, a mortality signal came out that just didn't make sense. And this happens when we do research. We get a hold of a database, we do some analysis, and the critical point of any type of statistical analysis is that when the data just doesn't make logical sense, you've got to do some data validation. You have to do some sampling. You have to see if there's unmeasured covariates that are confounding that. But that paper that came out and suggested that paclitaxel stents were causing deaths, it put a total arrest on drug-eluting stent technology, to the point that a lot of physicians wouldn't use drug-eluting stents despite their incredible patency rate, Drug-eluting stents in the peripheral vasculature has been one of the biggest advancements that we've had in the last 20 years in the peripheral space. And that signal, that red signal, put the FDA in a kind of hurricane response and essentially halted all drug-eluting stents from being utilized. And what the downstream effect of that, now we now know that signal really isn't there. The drug-eluting stents in the periphery do not cause mortality. We have 10-year data with breast cancer patients that have received 1,000x the dose of paclitaxel, and they're not dying from cardiac complications. We know that the covariates are mixed. So it is not a perfect industry. And I hope that as this data becomes more and more clear to the FDA, they'll be able to make better recommendations for us and turn back some of their language that they've used on the AFX2 device. So with that, I'll open it up. It looks like we have one question here. With the VQI data published, do you see this becoming the process moving forward of allowing current and future endografts? You know, I do. I think, you know, in the vascular space, the problem that we have is data. And it's a paucity of data. And the thing that is nice about the VQI is that now there has to be an incentive for surgeons to participate in these. And just doing it on your free time doesn't work. It has to be built into Medicare, has to be built into CMS. There has to be a payment for it to justify it. But the VQI for certain endpoints is very easy, like all-cause mortality, cardiac death, pulmonary death, et cetera. But what we really need in the EVAR space is digital databases. That's the only way we're going to define how these endografts perform. We know that self-reported type 2 endoleaks are very different than controlled reporting endoleaks. We know that self-reported on IFU, off IFU is very off. So we got to have a data set that is monitored and collected to bump it up into that level 2 data field. Without the monitoring, it's still just bad data. Does that help answer your question, Sean?
Yeah, thank you so much, Dr. Arthurs. Of course, this is Eric Gellinger. You know, we're so very thankful for you sharing your expertise and time. And again, as you mentioned, we're opening this up for questions, and we're so very thankful to your patience to field those. You know, one that we received before the call was, you know, given in the world we live in, the Google world, what would you say to a patient who maybe potentially is refusing AFX2 because of maybe what they saw on the internet regarding AFX1 and Strata?
You know, that's a good question. I have never, ever had that happen, you know, to me. You know, I would explain to them that every single device out there has had engineering problems, all of them. None of them have not. None of them have had a signal leap out like yours with kind of a group think, you know, issue. Many years ago, Medtronic had an issue with their limbs to where there were 3 to 5 type 3 endoleaks that came out. There were limb patency issues with other devices. The way I would explain to them is that all devices are in evolution and evolving to be better. And the current technology right now, I would explain to them why I choose AFX for them and for their anatomy, and why it's my first choice. And I would explain to them that the number one thing for me that drives it is access, limb patency, reintervention. And that reintervention rate is what drives their late mortality risk at 8 to 12 years. And I just have a discussion with them.
I gotcha. Thank you. Thank you so much. I'll help field some of these questions that are coming in. We had another one from Allegheny Health. Why do you feel type 2 endoleaks are less with AFX2, in your opinion?
My own opinion is the number one culprit that I see for causing persistent or new type 2 endoleaks are the low lumbars right at the bifurcation. When we do open aortic aneurysm repair, right at the bifurcation, just in front of the orifice of the iliac arteries, there's always a double barrel shotgun of two lumbars that are directly perfused by the hypogastric arteries. And on the flip side, there's also usually two lumbars about 15 to 20 centimeters right below the renal arteries. And when we do open surgery, we see those, we tie them off, it's no big deal. When you put in a straight tube like all the other devices, the fabric does not interact with those lumbars and does not plug them. But on my post-op CT scans, I never, ever, ever see those two low lumbars at the bifurcation, and I never see the proximals. If I have a type 2 endoleak with AFX, it's always an IMA and a mid-body, and I think that those are very different because it's a pressure head of collaterals. From the superior aspect, it's a gradient that, if the patient's systolic blood pressure is 120, by the time you get down to those low lumbars in the mid-segment, it's probably a pressure of 40 to 30. And the flow in those, when we look at them on ultrasound, is around 20s, 25s. But the high flow type 2 endoleaks are the ones that I think really are problems. And they have velocities of 35 to 45. And it's the proximal and the ones down at the bifurcation. And down at the flow divider, that AFX, it fills the distal portion, that fabric. We call it bellowing, but it's really opposing to the wall, and it seals those lower distal lumbars. And so there's just less lumbars to perfuse the sac and cause problems with a type 2 endoleak. And I think that's really the issue, is that it interacts with the sac wall over a greater surface area than all of the other devices out there.
Yeah, no, thank you. And then just, I guess, to stand on that subject, I had a question come in regarding, do you proactively coil the IMA to help prevent these type 2s, or?
So we actually had a trial at my institution in San Antonio. We had a trial set up and approved through our IRB to prophylactically embolize the IMA, leave a sheath in the sac, deploy a AFX device, and then do what we called sac ablation, which at the time we were going to use thrombin gel foam to keep it in the sac, shoot a saccogram and confirm that 100% contrast did not leave the sac, and do the follow-up. And at V that year, right when we were doing it, a group out of the Netherlands did the same thing and showed 100% sac stability or regression. And in that same year, the Endoleaks data came out, and we stopped it because we thought Endoleaks was going to come on board and solve the sac problem.
Right.
And to an extent it does. Technology is so unforgiving, both Ventana and Endoleaks. Endoleaks does fix the type 2 endoleak rate. It took the type 2 endoleak rate down to a number that was 1%. And even those endoleak rates from Endoleaks were very, very different than what we see with our current devices. It was like a little blush around the edge and a little flow around the edge. It was not near the endoleaks that we had, and it doesn't have the sac expansion like what we had. The proximal neck issues with Endoleaks turned into a sideshow, but the real sweet sauce of Endoleaks is the sac technology. So we never completed that. And today I don't prophylactically embolize it because that reintervention is 20, even if it is 20% in your patients at 8 years, that's still 80% that don't need an intervention. So I'm going to do, 8 out of 10, I'm going to prophylactically interrogate somebody's IMA and potentially cause a problem with their bowel when I just don't need to.
Gotcha. Yeah, another one came in from Dr. Wozniak. Adding a little bit to this, that the peripheral disease reintervention rates, and having to be able to preserve the native bifurcation in comparison to modular grafts. How important is it to preserve that natural aortic bifurcation when using EVAR's devices?
So 2 points there. Number one, I think it's incredibly important. You're using the patients, in all aspects of vascular surgery, the principles are to maintain their normal anatomy. Every single distal bypass we tunnel it anatomically because that is the best route and the shortest distance to prevent keeking, twisting, turning, everything. When we start doing extra anatomic devices, we have problems because it's outside of the patient's normal aortic anatomy and we get kinks and turns. A retrograde SMA bypass. If we do an antegrade SMA bypass, there are much less problems with that when we keep it in anatomic conformation of their anatomy. The same with putting a floating flow divider in the middle of an aneurysm sac. There's a huge amount of stress on that floating flow divider, and we can cycle it. We can test it in the lab. We can run it through so many life cycles, but it's an incredible amount of force on that flow divider, and it is shifting in a breeze with no support. Any other device that we put in the body and tunnel, the scar tissue and the natural tissues around it scarred into place and help stabilize it and minimize movement. That doesn't happen with an EVAR. It's in the middle of the sac. And when you put a force zone right in the middle of the sac, it puts an incredible amount of force. And when migration was a problem, this is when AFX came out. They basically took the device and put it on the flow divider to take that force equation out of the problem completely, so that there's no stress on the most important aspect of the case, which is the proximal seal zone. And when it comes to preserving it, one, I think it's important from an engineering standpoint. I think it's important from a longevity of the device standpoint. And I think it's important from a patient standpoint. I would say 70%. It used to be 10 to 20% of aneurysm patients had PAD. Now it's really closer to 70 to 80% of my patients have PAD in practice. And being able to go through that bifurcation, it used to be kind of 1 or 2 a year. Now it's pretty frequent that I find myself needing to go back through that. And if I need to re-intervene from a endoleak standpoint, I also find it beneficial to be able to go up and over, work through the hypogastric and get out into the pelvic circulation. So for me, I find it to be critically important.
Thank you for sharing that. So just going back to you mentioned the VQI vision data. And just given the strong data that from the VQI vision presented in the British Medical Journal, do you see more discussion coming about head-to-head performance of AAA devices, and how should this drive decision making for the average vascular surgeon? How can they use that head-to-head information? Or
it has to. We have to get there, and we have to get over this hurdle. And it is a little bit of groupthink there on it, but there's no doubt that CMS, Medicare, all of our payers are going to want to see head-to-head data, and technique is important. That's what we focused on, and that's what VQI focuses on. But we're really not giving the credit to where the engineering is, and the engineering in our technology is equally important and is an equal factor. And so I do think that if we're going to critically analyze our outcomes, we have to respect the engineering, and we have to put them head to head to really see what the performance is. And if I'm a company and if I'm an engineer, I want to know that data. Just like Endologics, you spend all this money forecasting in the lab, trying to come up with the constraints. There's nothing better than seeing how your device performs against the competitors from an engineering standpoint. And so I think it's definitely coming. And I think as a specialty, we need to encourage it.
Thank you for that. I'm kind of going to build on that one a little bit. So what data point really resonates with you the most? I mean, maybe provides enough credibility to overcome all those previous FDA letters regarding the previous version of AFX1 with Strata. Is it LEOPARD? Is it the VQI Vision? Is it really your personal experience? What have you found has just made, the most sense to you?
The thing that makes the most sense to me is that all devices are pretty good at obtaining a type 1 endoleak, a type 1 seal, 1A and 1B for 5 to 8 years. After 8 years, I really don't know. I wish I had a monitored data set to look at. I would love that to see what happens, because I think the neck problems happen beyond 8 years, neck dilatation. And we know that and I would love to look at the data set from LEOPARD, because we know that neck dilation happens with self-expanding stent grafts. I've done a paper myself that is, it blew my mind. I went back and looked at all the patients that needed a Palmaz, and most of the patients, their aortic neck continued to dilate out to the size of the self-expanding stent graft, and the Palmaz was often down at the flow divider, it embolized or was freely floating. And so you had an internal, steel ring as your internal collar measurement. And then over time, the neck outgrew that stainless steel device, and then it embolized. So we know that the self-expanding stent grafts are not good for the neck. And that failure mode, in my opinion, happens at the 8 to 12 year mark. But out to 5 to 8 years, they all do pretty well from a 1A, 1B. The type 3 endoleak rate, I think they all do pretty well. The thing that I think really is the distinguisher is the type 2 endoleak rate. And that's the thing that we understand the least across the devices. But I definitely think that the AFX device outperforms all from a type 2 endoleak rate. And that type 2 endoleak rate is 100% what drives the reintervention rate. And we used to all think that reinterventions were free. We used to not think about it at all. They're not. And when I talk to people that do type 2 embolizations and chase down these type 2 endoleaks, transcaval embolizations, translumbar embolizations coming from the IJ, some of them take 5 to 6 hours. Some of them under general anesthesia. There is a mortality risk to it, and it adds up. It's cumulative. And most of these patients that have type 2 endoleak rates, it's not just one intervention. It's 2 to 3 interventions. And we have no good data on the treatment of type 2 endoleaks that shows that our interventions actually halt sac progression and stabilize it. The longest follow-up we have for type 2 endoleak treatments, this is a talk that I give at VEITH last year. The longest follow-up we have is about 12 to 16 months, and it's on unmonitored data. And most providers that follow their patients after a year and a half will comment that the durability is not there. So the best thing you can do for your patient is set them up with a device that has the lowest type 2 endoleak rate from the outset.